realize that. You know what? I will be right back. One, two. It's working in here. I hope it's working in here. Okay. Friends, we're going to begin. If you would take your seats, I would appreciate that. Thank you. Mark, but I'm not sure if I'm going to, but when you speak, you're welcome to. Oh, I'm not going to take that. Yeah. Take your time, Bert. All right. Sheldon, can you do me a favor? If there are any stragglers back in the auditorium, would you ask them to come in? I would appreciate that very much. We're only half an hour late, that's all. Anyhow, I want to allow me to welcome all of you into the warmth and still the familiarity of our beloved Molish sanctuary. So Shavua Tov to all of you. You know, it's so wonderful to see you, as we say in Hebrew, basar vadam, in the flesh. So many of you I have seen from 1 week and 1 month to the next in your Zoom box. Never. Although thank God we have that technology, and of course live stream as well, which reminds me, we welcome, I hope, many fellow Bethomnics who are with us on live stream. We are delighted to have you with us this morning. Do you want to turn around and do you want to greet our fellow Bethomnics, if you would, folk, with a wave? I know that they would appreciate that. That's beautiful. Thank you. Yep, the camera's right there. We thank Barry, by the way. Barry's in his closet this morning. So Barry, thank you. Thank you for taking care of live stream. We do appreciate that. I'm very much mindful of the fact that other than regular weekly Shabbat religious services, whether in person or online, this is our first educational program in person for this secular year 2022. And so I think it behooves us to recite together the bracha that is most appropriate, that brings us together, as I mentioned on Zoom yesterday morning for Torah study, as a kihila kedusha, as a holy, sacred convocation, assembly, congregation of fellow Bethomnics. And by the way, we have a number of visitors, and we are delighted to welcome you this morning. Together, Baruch Atah Adonai, Eloheinu melech haolam, she'achiyanu, v'kiyimanu, v'higiyanu, lazman hazeh. Friends, at the same time, we would be entirely remiss, of course, if we didn't take into consideration the extraordinary bravery and the heroism of the Ukrainians at this time of extraordinary peril and of uncertainty, of naked aggression that they have had to face in the face of such unbelievable evil. I should mention to you that there are still, it's believed, about 40,000 Jews left in the Ukraine. Our thoughts and our prayers are very much with them, and of course with their fellow brethren throughout the length and breadth of that brave country. Some of you, and one or two of you, have already mentioned to me this morning that your immediate relatives indeed were born and came from the Ukraine. Mine came from Lithuania. But nevertheless, the history of the Jewish community in the Ukraine is a rich and illustrious and noble one. Dark, of course, to be sure, but nevertheless, it behooves us to take into consideration all Ukrainians at this time as they try their very best to regain, or at least to maintain, full independence and sovereignty. And so would you join with me in these words that we're all familiar with? We'll sing them together. Ose shalom bimromav, hu yaseh shalom aleinu, ve'al kol Yisrael, ve'imru amen. Yaseh shalom, shalom aleinu, ve'al kol Yisrael, Yaseh shalom, shalom aleinu, v'al kol Yisrael. To Ukrainian President Volodymyr Zelensky, to his government, to the citizenry of the Ukraine, we say, Chizku v'imtzu, may you continue to be strong and of good courage. And on a personal note, may I also remind you, if I may, please give me one, our very own bookkeeper, Yelena Korochuk. Many of you have had an opportunity, of course, either to speak with her or to have met her. Yelena is from Kiev. Her mother, her brother, sister-in-law, and 2 nieces are currently at home in Kiev. Although, if I remember correctly, because I did text her yesterday, just to find out what's happening and to let her know that my thoughts and prayers are with her family, they have sought refuge at her sister-in-law's family's home, which apparently is outside the city center in the suburbs of Kiev. On a much happier note, I hope that you have already, I know that Sandy, I asked Sandy the question, she confirmed that she has received all of this publicity. I'm not sure, if you haven't yet, you will receive it, I think in a matter of days, in the mail. Please be sure to look at it if you would. We want to thank Stacey Mott, one of our new secretaries, for having undertaken this responsibility. It's an all-color, timely brochure, timely topics for March, all the current up-to-date information that you need for events later this month and throughout the month of March are to be found in this publicity. Please be sure to take note of it if you would, and we hope that you will join us. Wednesday, March the 16th, 7 p.m. I know that Josh has already mentioned it, an adult Purim celebration that we will have upstairs in the, not upstairs, in the Strick Auditorium at 7 p.m. And may I remind you that it was our annual adult Purim celebration of 2019 that was the last in-house program that we had here at Beth-Am before we closed this building. Never forget that. So, all the more reason to be with us. And of course, I'd be remiss if I didn't mention very quickly, Mark, the Hallelujah, the Bimmer to Broadway cantorial concert that will take place right here, God willing, on Sunday, April the 3rd. Grateful thanks to Reedy and to her committee for everything that they've done to support this. By the way, it's not only a 75th celebratory event, it is also especially a celebration in honor of Cantor's Ark's Double Chai, 36th year here at Beth-Am. It's a remarkable professional accomplishment. God bless her, and we look forward to celebrating. So having said that, it's my very great pleasure, albeit very briefly, to say how delighted, Mark, we are to be here with you this morning. We congratulate you, sir, on your magnum opus, as it were. We trust that there will be more books that will be following. Rheum, R-H-E-U-M, Rheum for Improvement. Mark and Susan have been members of Beth-Am for, according to my records, my reckoning, approximately 23 years. During that time, they have truly been steadfast, devoted, committed Beth-Amniks in every sense of the word. Susan was and has returned to the Mensch Lab faculty. She's currently a 7th grade teacher, specializing in Holocaust studies, which is her primary interest in life. And we thank you so much, Susan, for having acceded to the call from Rabbi T and myself. We're grateful for your expertise and the knowledge that you are providing our students at this time. We want to welcome Dana and Melanie back to Beth-Am. It's so good to see both of you. And at the same time to also welcome Melanie's fiance, Josh Chazen, who I'm meeting for the very first time, and look very forward to standing with you under your chuppah later this year on October the 23rd, if I remember correctly. So Mel, Josh, congratulations. Mazal tov to both of you. Dana, so good to welcome you back. Very, very much indeed. Mark, as you probably know, was in professional life for a rheumatologist for no less than 28 years. Now, allow me to say this, if I may, sir. I don't want you to take it too personally. Unlike many congregants, I am very grateful that I never had to see you in a professional capacity. But I know, and by the way, should that day come, as no doubt it will, I'm still going to seek your professional advice, whether you're retired or not, Mark. But I know for a fact that there are many congregants, some of whom are here today, who have sought your counsel, your professional expertise, your advice. You are the best of the best, from what I'm told, in your professional discipline. Your reputation has exceeded you for so many years already, far and wide. I mean, look, I've had the great pleasure. Randy and I have traveled with this couple, Mark and Susan. I mean, we've traveled to Israel, to South Africa, to Morocco, and I know that one or more folk, fellow travelers, took you aside for a sidebar conversation. We are so grateful to you, Mark, to you, Susan, in another capacity as well. And I trust that all of you know this by now. Mark and Susan LePatten took it upon themselves to be the co-chairs of our 75th anniversary Jubilee year. So over and above all the festivities that you have to plan for later this year, and teaching responsibilities as well, the fact that you've taken on this enormous responsibility on our behalf is something that we are so very grateful for. And your fellow Beth Omnics join me in thanking you for having agreed to be the co-chairs of this Jubilee year. Ladies and gentlemen, fellow Beth Omnics who are with us and those online, on live stream, it's my very great pleasure to welcome to the Bima our fellow Beth Omnic, the distinguished Dr. Mark Lepatin.
Can you hear me without a microphone? I'll use the mic. Rabbi, thank you so much for your kind words. Now my head's so swelled up, I'm not going to be able to get out of the room, but thank you anyway. I can't tell you how excited I am to be here because I don't always get a chance to pull out my soapbox and speak from it. Today I will. What I'm going to cover today is I'm going to take you all on my personal journey in advocacy. I'm going to explain how I evolved from where I was to where I am now, the events that took place that triggered that change in me, that evolution, the evolution of a healthcare advocate. I'm also going to touch base on some of the issues that affect patients, specifically specific examples of things that compromise the care that patients receive. And then I'll talk about things that we can do together. I'll also read a few excerpts from the book, and we'll go from there, and then we'll open up to questions and answers. For those of you who know me, you may find this hard to believe, but I was not always this outspoken about things. Growing up, I was pretty shy, I was pretty quiet. I think the word that comes to mind is clueless. I was pretty book smart. I knew how to calculate the area of a circle, and I knew how to solve quadratic equations. But in terms of things like bureaucracy, politics, racism, anti-Semitism, I knew nothing. I didn't even have basic skills in relationships or communication. So for me to get from there to here, there's a lot that took place. I'm going to share those events with you. During my time growing up, there was a lot that happened. Kennedy assassinations, Martin Luther King was assassinated, Watergate, the war in Vietnam, man landed on the moon. My memories of childhood, Joe Scarpati stole the ball to save an Eagles victory in 1966. The Flyers missed the playoffs when Jerry Meehan scored with 4 seconds left in 1972. And of course, who can forget Black Friday for the Phillies? So these are the things that were important to me growing up. But I was going to be a doctor. It was ingrained in me from a young age, and I'm not sure why. I was going to be a doctor to help people. That's always a standard line. But I had no idea what that involved, and I had no idea what that entailed. And I was about to learn quite a few lessons. Interestingly, the lessons that I learned were swallowed whole at the time. They were digested, but I never tasted them. I never stopped and consciously thought about them until I wrote this book and realized how much that I had learned. And I'm going to share some of those things, some of those experiences with you. So let me take you to my third year in medical school, and it is time for me to do my clinical rotations. And that means being assigned to a hospital, and you're going to see patients at the hospital. And I was assigned to go to West Park Hospital for my first rotation. West Park Hospital was a dinky little hospital in West Philadelphia, in Bowen Park. It had a very poor reputation. The attendings there didn't know anything, according to us hotshot residents, and I did not want to go there. I wanted to go to a more high-powered place where I could learn medicine and be a great doctor. And I spoke to my advisor about it, and she said to me, Mark, what you learn and how well you do as a physician does not depend on where you do your rotations. It depends on you and what you make of it. And thinking about it and thinking on it now, I remember Rabbi Lieb's words, pray as if everything depended on God, act as if everything depended on you. And that is so true, and it's especially true in healthcare, and especially true in healthcare advocacy. I mean, I have people come up to me and they say, my doctor won't listen to me, and they're making me see a nurse practitioner instead of the physician, or they won't return my phone calls. And my response is, what have you done about it? What have you said? Oh, I can't say anything. I don't want to make waves. I don't want to make a fuss over this. And the question I asked them then is, what would you say if it were your grandchild instead of you? Would you be willing to speak up for your grandchild? And if you're willing to speak up for your grandchild, then you have to speak up for yourself. And that's a message that I want to get across to people, is you have to speak up. One of the main messages in this talk is that healthcare should be a human interaction between a patient and a physician, rather than a business transaction between a consumer and a provider. And it's up to each of us to speak out when we see these circumstances that arise to correct the system. It's not always going to be talking to legislators to get them to change laws. Sometimes it's speaking to an individual doctor, an individual office, to try to change your cause, of course. So that was a very valuable lesson for me. From there, I finished medical school. I went on to do my residency, and I got my first taste of bureaucracy. And that was at the VA hospital in West Philadelphia. I've oftentimes commented, the only reason that VA hospitals exist, it's not to take care of veterans. The only reason they exist is so that people like me have stories to tell later on in life. And there are a slew of stories to tell about the VA. I'm going to share one specific one, and that involves the anti-nurse. Now, in common lexicons and so forth, you hear about the Antichrist, who is the opposite of what Christ should be. Well, the anti-nurse was the epitome of everything that a nurse should not be. She had a grudge against doctors and did everything to torment us. And I just want to share an excerpt for you, talking about the anti-nurse. Once I received a call in the middle of the night to advise me that my patient's temperature was normal. When I asked the anti-nurse why she had woken me up to inform me of this, her response was, "I just thought you'd want to know." At 3 o'clock in the morning? One of my colleagues once got a phone call in the middle of the night informing him that a constipated patient for whom he had ordered a laxative had just had a large bowel movement. I routinely got calls for the next day's medication orders. Oftentimes, the dosage would depend on the results of the morning labs, so there was no way I could answer the question in the middle of the night. I would get phone calls waking me up, asking for orders for a patient's lunch the next day. There was no reason this question needed to be asked in the middle of the night as opposed to the next morning. But the big story that happened with the anti-nurse was one specific incident when one of my patients, one of my confused patients, decided he wanted to see what it would be like to be a urologist. He had a Foley catheter in place. Now, for those of you who don't know, a Foley catheter is a tube that is inserted through the penis into the bladder. There's a balloon that's inflated to hold it in place so that for men who have difficulty urinating. So he had a catheter in place, he got up out of bed, and he decided he was going to remove his Foley catheter. He didn't just gently pull the catheter, he yanked it. And he forgot, or he never knew actually, that you have to deflate the balloon. Well, needless to say, he was spraying blood across the room. The room was right across from the nurse's station, and I yelled out to the anti-nurse, "I need help now." "I can't come, I'm giving report." "No, you don't understand. I need another set of hands now." She refused to come help me. I did the best I could under the circumstances. I got the situation under control, but her refusal compromised that patient's care. And it was not the last time that I saw behavior that negatively affected patient care for people who had other agendas. And that runs rampant in healthcare today. We complain, by the way, it was not just me. Her passive-aggressive behavior was directed at most, if not all, the residents. And we swapped stories, each one more absurd than the one before it. We complained to the administration and were told that there was nothing they could do. She had tenure. This was bureaucracy at its finest. Once again, it would not be my last experience with it. So I finished my residency, and I was competent. I knew how to manage all kinds of things. I knew how to take care of a patient with a heart attack, or patients with congestive heart failure or septic shock. I often joked I knew how to take care of these kinds of patients. I didn't know what to do with a sore throat or a cold, but I knew how to take care of the sickest patients. I knew how to take care of patients. I didn't know how to care for patients, at least not at a conscious level. And that lesson was hammered home for me the year after I finished my residency. I was running a clinic in the year between my residency and my fellowship, and it was there that I met my patient, Frank. And Frank was a 25-year-old African-American male with AIDS, and this was right at the time when AIDS had first come out. It was still a new diagnosis, and a lot of people were scared by it. And he became my patient. He was very quiet, very scared, and quite appreciative of the care that he received. I liked him, but he was one of many patients, and I had no special bond with him. I knew he would not do well in the long run. I knew I could not prevent his death. Nonetheless, I did what I could for him. I tended to his needs, answered his phone calls, brought him into the clinic when he needed to be seen, and listened to him. I felt some sadness when he finally died, but did not give it too much thought until I received a note from my nurse in the clinic. She was not one for sentiment, yet she wrote the following. Oddly enough, I'm not very good at expressing my feelings in writing, but I want to thank you for your care and concerns for Frank and for me. If ever you wonder if it's all worth it, or if you make a difference in a patient's life, just remember Frank. You gave him respect, consideration, and self-esteem, as well as a feeling of security. He had, quote, his doctor, end quote, to turn to when ill or scared. I'm proud to know you and to work for you. Love, Nell. Nell was a nurse, but she inherently understood that there was much more to medicine than simply knowing how to diagnose and treat disease. This was my first conscious lesson on the importance of humanity in healthcare. It would not be my last. Fast forward to my fellowship. I got a similar lesson. During my fellowship, I was very active in the Charity Variety Club, which is a children's charity. And one Sunday afternoon, we were running a celebrity bowl-a-thon right here in Willow Grove. And I got a call from the emergency room at Jefferson that my patient was in the emergency room with pericarditis. She had lupus. Pericarditis is inflammation of the lining of the heart, and it's commonly seen in lupus. And she was going to need to be admitted. So I gave them orders, told them what to do, what meds to give her, and said I would be in to see her the next day, Monday, when I was down at Jefferson. End of story. I went back to the celebrity bowl-a-thon. Then I got a phone call from my attending who said, are you on your way down to the hospital? I said, no, I'm at a celebrity bowl-a-thon. He said, you need to get down to the hospital. I said, why? It's not going to change anything. I've already given them the orders what to do. They know what to do. I'll see her tomorrow. Nothing's going to, no difference. He said, Mark, you are her doctor. She is your patient. You are obligated to go see her. And I grumbled. I complained. I left the celebrity bowl-a-thon and drove down to Jefferson, an hour-long drive from Willow Grove. Saw her in the emergency room. I was 100% correct. Nothing changed. There were no orders written, except that she was scared. And just seeing me, to give her that reassurance, made a huge difference in her care. And I learned that healthcare is not just about writing for the right medicines, making the correct diagnosis. It's a people connection. We're losing that. One last story I'll share with you that occurred after I was attending that I think this crowd will relate to about the humanity in medicine. And this is from the physician's perspective, not the patient's perspective. It was a Tuesday. It was Yom Kippur Eve. So I wanted to get home that night to eat dinner with my family. Rabbi Lieb knows this story. I wanted to get home to my family at a reasonable time. I mean, I had patients scheduled till 5. That meant I usually got home around 6:30. And I was doing everything in my power to make sure I got done that day on time. I was very efficient. As of 2 o'clock, I was on schedule. That's like unheard of. I was on schedule. Until I got a call that there's a consult in the hospital. Now, a consult in the hospital means I have to walk over to the hospital. This is Doylestown Hospital. I have to walk over to the hospital, look at the chart, examine the patient, write up a consult. It usually adds about an hour to my day. And I was annoyed because I wanted to get home in time. So I walked over to the hospital, looked at the chart, nothing unusual there. I went in to see him and was greeted by a white male with multiple tattoos of swastikas covering his body. And I was speechless. And a million thoughts ran through my head. Do I have to see this patient? What if this patient needs care beyond this visit here? What if he needs to be seen in the office? Can I see him in the office? He's not going to know that I'm Jewish. How do I disguise my contempt for him? And what I did was I squeezed my doctor's hat on more tightly and said, you're a professional. This is someone in need. You need to do whatever you need to do, and you need to ignore the obvious message that's all over his body. And he didn't know I was Jewish, and we had a pleasant visit. There was, a civil visit, and I took care of him, and I did what I needed to do, and I was so relieved when I got done that I didn't have to see him in the office. But healthcare is a human proposition, both from a patient standpoint and from a physician standpoint. So I learned all these lessons, even though I didn't consciously process them necessarily, but I learned all this. But these did not turn me into a healthcare advocate, and these events did not turn me into an outspoken person on the political front. That process started on a December evening at 8:30 in 1999. My kids were still young. I'd put them to bed. At 8:30 at night, there was a knock on my door. When there's a knock on your door at 8:30 on a Sunday night, it's usually not a good thing, and this was no exception. There was a man there who said to me, "Are you Dr. Lopatin?" I said, "Yes." He handed me papers that would change my life. I was being sued. I can't begin to describe the feelings of terror that run through you. Getting sued for malpractice is not like getting sued for a car accident. We identify ourselves as physicians. We identify ourselves by the job that we do. So, I was in a car accident a few years later and got sued for that, and it didn't bother me in the least. But this is your core identity. When you get sued as a physician, when you meet somebody at a party, you judge them immediately based on age and gender. You form conclusions. You ask them, are you married? One of the first questions you ask is, what kind of work do you do? We identify ourselves. So basically, suing me as a physician, you are attacking my identity. I barely slept that night. I couldn't wait. This was before electronic medical records. I couldn't wait to get to the office next morning to see what I had done. As it turned out, it was a patient with fibromyalgia, which is a chronic pain condition, widespread pain condition, who had seen me 2 years before. At her initial visit, I diagnosed with fibromyalgia. Her primary care physician had started her on a new medicine the day before she saw me. I said, let's see how you do with that medicine before we make any changes. She came back a few weeks later. She was feeling much better. The medicine was helping her. I saw her a third visit several months later and saw her for the last time in February of 1998. 4 visits total. I didn't do anything for her. I was being sued because I failed to diagnose her meningioma, which is a brain tumor. Now think about that. I'm an arthritis specialist, joint and muscle disease, and I'm getting sued for failure to diagnose a brain tumor, something outside my realm of expertise. On top of that, I went back and looked at my initial notes. My initial notes, I clearly asked, any problem with headaches, which is the cardinal symptom of a meningioma? She said no. So I ended up getting sued for something outside my specialty in a patient who denied the cardinal symptom of that particular malady, even though I specifically asked about it. There was no case. My lawyer reassured me. The plaintiff's attorney refused to drop the case. The case lingered on for 1.5 years with me worrying about it until my attorney finally threatened a citation for contempt. It was only then that the lawsuit got dropped. But it was a harrowing experience. It got worse because 2 months after that lawsuit I learned of that lawsuit in December of 1999, I got word that I was being sued again This is in February of 2020, and this was a much more threatening case. This was, again, a lady with fibromyalgia, widespread pain, who had 10 years of chronic pain. She came to see me, I treated her, we did some things, we established a relationship. He was a little bit ornery and suspicious. She was not the easiest patient in the world. She had a notebook full of records, and she was a challenging patient. But we started to form some semblance of a relationship. Sometime in April of 98, or March of 98, she developed hearing loss. She went to see an ear, nose, and throat doctor in Philadelphia who diagnosed her with something called autoimmune sensory neurohearing loss, which is treated with steroids, and he started her on steroids, prednisone 60 milligrams. He referred her to another rheumatologist. She saw that other rheumatologist, and he didn't accept her insurance, so she came back to me on an emergency basis, demanding to be seen. I saw her on an emergency basis on April 13th that year. Nothing unusual. She was complaining of pain. She said she thought the steroids were posing a problem to her, but it's hard to draw any conclusions about someone who's been in pain for 10 years that this pain is different. In June of that year, she complained specifically of knee pain. Previously, her pain was all over. She complained of knee pain. I ordered an MRI of her knee, and it revealed something called avascular necrosis, which is damage to the bone. It's a loss of blood supply. It's kind of like a heart attack in the bone. And it's a potential side effect of steroids. It's not a common one, but it's a well-known one. She went to see an orthopedic surgeon. She started complaining of other joint pains. He ordered MRIs of other joints. She had widespread avascular necrosis, and she blamed it on the steroids. The steroids that were prescribed by another doctor. Now, I weaned her off the steroids very quickly. I got her off the steroids in about 5 months. Usually for something like this, it's more than a year. I got her off very quickly. I made the original diagnosis. I ordered the MRI that made her diagnosis of avascular necrosis. And in August of that year, she sent me a note thanking me for helping her to coordinate some care. In February the following year, I got a phone call from that other rheumatologist asking me why he was being sued. He only saw her once. And he also happened to inform me that I was being sued as well. I was stunned. I met with my lawyer. My lawyer told me, looked at my chart, great job, you've documented this all beautifully. You've done nothing wrong. In fact, the care, there's nothing that needs to be changed. I looked at the chart myself looking for what I would do differently. Nothing I would do differently. Then he said to me, throw it all out the window. It makes no difference. Because that ENT doctor was in Philadelphia, your lawsuit's going to be in Philadelphia. Philadelphia is considered one of the #1 judicial hellhole in the United States at the time. And what that means for a physician, and what that means is that, as he explained to me, is a jury is going to make a decision not based on the facts of the case. They're going to make a decision based on what they think of the plaintiff, how injured the plaintiff is, how much sympathy they have for the plaintiff. That's what's going to influence their decision. He said, so you can throw your medical records out the window in this case. That was earth-shattering to me, because that meant that if I went to trial and I lost, what's at stake? Is my house at stake? Is everything I've worked for at stake? A very frightening proposition to me. And I was scared. I was relatively young. I was relatively naive. I was scared. And he said to me, I think you should settle this lawsuit. I said, even though I didn't do anything wrong? He said, yes. The other issue with it was because of something called joint and several liability in place at that time. That meant that if I was found even 1% responsible for her injuries, I could be on the hook for 100% of the damages, depending on what the other plaintiffs could afford. That was too risky a proposition. I settled the lawsuit. And I said to myself, as I did this, how do I look my children in the eye and say to them, you need to fight for what's right, when I'm settling a lawsuit, when I knew I did nothing wrong? Very traumatic for me. I needed counseling. Susan will tell you how much venom I had inside my system. I could not get it out. No matter how much I vented, no matter what I did, I could not get the venom out of my system. This is when I started to become politically active. I joined an organization called the Politically Active Physicians Association. I began to write letters to the editor. I was not very fond of plaintiffs' attorneys, although I will tell you, ultimately, I learned that you don't generalize about a profession. And I actually became chair of the medical legal committee for Montgomery County. And I started to work with lawyers and learned, once again, you judge people based on their individual attributes, not their profession. And there are many plaintiffs' attorneys who are very honorable and are doing right by their patients and doing the right thing. You don't judge them on that basis. But I had to learn that. But I was angry. I got through it with counseling. I started to support political campaigns, most notably initially Ellen Bard. Had a little incident with Josh Shapiro. I did not support Josh Shapiro at the time. I actually had a run-in with his father, who is now a good friend of mine, at an event, and he said, "How can you not support my son?" And I said to him, I don't have the confidence that he's going to be able to stand up to the Democrats, which at that time were the party of the trial attorneys, and I don't think he's going to be able to do that as a freshman representative. By the way, at this time, getting started in politics, I entered on the Republican side because the Republicans were the ones who were fighting for tort reform and fighting to make changes that were important to me. And I was a one-party voter. That was the thing that mattered to me at the time. So I'm a Republican. Josh Shapiro actually went on later to prove me very wrong in my statement that he would not be able to support the right thing and would not be able to stand up to his party. He did. He and I talked about it. He's become a friend, and I support him wholeheartedly. Give a little plug for Josh here in that regard. One of the other things I did was I organized rallies outside Abington Hospital, protests of doctors, standing along Old York Road in front of Abington Hospital. It made national news. An AP photographer took a picture of that rally, and there's a picture of me standing there with my sign saying, "Sick? Call your lawyer." That picture made it into USA Today twice, and even Time magazine. So I had my 15 minutes of fame with my picture in Time magazine in 2003. So I started to do this stuff, and then the typhoon hit me. And this was a patient, again, with fibromyalgia. There's a reason I stopped taking care of chronic pain patients. A patient with fibromyalgia was referred to me by one of my patients. She drove more than 2 hours to see me. When she came to see me, she was on Vicodin. This was before the opioid epidemic. And at the time, the teaching was that physicians are not taking care of pain adequately. We're under-treating pain. The teaching was that pain is the fifth vital sign. It should be part of every visit. The teaching was that opioids are not addictive in and of themselves. Addiction is a function of the individual patient, not the drug. And that there's no ceiling to the doses of opioids. These are all since been found to not be true. But that was the teaching at the time. And I escalated her dose. I got her changed to a long-acting opioid, high dose, got her pain under control, and she was on that dose for 3 years stable. She was admitted to another hospital with kidney failure from a separate problem, and the doctors there saw her dosages of OxyContin and said, "Who has you on such dosages?" And they told him that this was wrong, the patient and her husband, this was wrong, and they told them, patients, that fibromyalgia didn't even exist. They lodged a complaint with the State Board of Medicine. The State Board of Medicine investigated me for indiscriminate use of opioids. And by the way, the language that gets used in lawsuits and so forth is horrible. Wanton disregard, reckless endangerment. I mean, just horrifying language that's designed to scare people. It works. I was scared. But this time I was up against an opponent that I'd never encountered before, and that was a fraudulent witness. The expert witness they hired was someone who had completed a one-year family practice residency. He had no training in rheumatology whatsoever. He had done no residency, and he made his and that was back in the 60s. This was in the early 2000s, and he made his living testifying against physicians. With some legal stuff that had happened in 2002. If this had been a lawsuit, he would not have been eligible to testify against me. He didn't meet the criteria of having done training in my specialty, board certified in my specialty, et cetera. We pointed that out to the state board. They said, we don't care. This is not a lawsuit. My malpractice attorney, my malpractice company, would not pay for the litigation because it wasn't a malpractice suit. I paid more than $30,000 out of pocket to defend myself in this particular case. Now, when you talk about a lawsuit, there are two things in a lawsuit. There are facts and there's opinions. And it's one thing to offer an opposing opinion. So for instance, I started the medicine A at 50 milligrams, and the expert witness says you should not have started, Dr. Lepan should not have started the dosage at 50 milligrams. The dosage should have been started at 10 milligrams and worked its way up to 50 milligrams. Okay, that's a difference of opinion. That's acceptable. Different people think differently about that. That's fine. But he made at least 30 errors of fact in his report. In the example I just gave you, he says dosage of medicine should not be started at 50 milligrams. It should be started at 10 milligrams. The problem was, I started the medicine at 10 milligrams. She was accusing me of for not doing something that I had done. He accused me of not having a history and physical on the chart. He accused me of not identifying fibromyalgic tender points, which were all blatant on the chart. There were at least 30 errors of fact, and I actually said to my attorney, have you given him my chart? Has he read my chart? He said, yeah. And the case went to trial. And I just want to share an excerpt from that because that was a seminal moment in my life. At the trial, I finally met Dr. Z in person. He extended his hand to me, and without thought, I shook it by default. I immediately regretted it. That single act of civility has haunted me ever since. How could I possibly have accepted the hand of someone who was intentionally trying to destroy me without regard for the truth? I sacrificed my self-respect in that instant in the name of good manners. I've not been able to come to terms with that, even after all these years. It was truly a life-changing action for me. I was already 48 years old at the time, but I learned a lot about myself and grew up quite a bit that day. Courtesy and consideration are important, but should not be rendered to those who engage in unethical behavior. Needless to say, I needed more counseling after this. I got through it with nothing more than a slap on the wrist. The State Board of Medicine mandated that I take a course in prescribing opioids that, frankly, I could have taught. I took the course, it was behind me, and now I had to move on. That was difficult. I needed counseling. I got through it. Throughout all this time, I had been working on tort reform. I had been lecturing on defensive medicine and how the need for tort reform affects patient care. I had been talking about all this stuff. And that lasted till probably the end of the aughts, till about 2010. Big change at that time was social media. In 2009, I started on Facebook, 2016 on Twitter, and began to realize that there are other things there besides tort reform and other issues that came up. We're going to talk about some of these in a minute. So issues like prior authorization, issues like scope of practice. And tort reform, there were some changes made in the legislation regarding joint and several liability in 2012, and tort reform kind of, and in venue, and tort reform kind of fell off the menu in terms of being the important issue. It was the one issue physicians were fighting for from 2000 to 2010. So what I want to talk with you now about is some of these issues and how they affect patient care. And let me start with documentation. In 2015, Centers for Medicare and Medicaid Services issued new regulations. This was a 962-page document called MACRA, which dictated how physicians are reimbursed. And what it did was it set forth a number of metrics that physicians were expected to meet at each visit to show that they were a good doctor. And the only way you can demonstrate these metrics are to check off a box. So there's questions, you check off the box. So if you wonder why your physician has their nose in their computer, they're busy checking boxes to satisfy Medicare requirements and actually insurance requirements because third-party insurers follow Medicare guidelines. So they're trying to meet these metrics. Some of the things that are not considered metrics, empathy, compassion, caring, those aren't part of the equation. And if you don't have the boxes checked off, then you're not reimbursed properly. So let me give you an example of this kind of thing. One of the things we're expected to document is pain. What is the patient's pain level? Interestingly, one of the criticisms of me from way back when in my opioid case was that I had failed to document the level of pain from 0 to 10. Now the chart documents she's in severe pain, but I didn't quantify it. Well, pain is not something that you can quantify. One person's 8, if you're talking about a 0 to 10 scale, one person's 8 is another person's 2. So I'm not sure what 8 means or what 2 means. But anyway, I'm expected to document the patient's level of pain with a numeric scale, objectify something that is inherently subjective. So let me give you an example. Patient comes to see me in January, and they've got rheumatoid arthritis involving their hands, and they tell me their pain is a 7. I give them a treatment. I see them back in a month. At their follow-up visit in February, they tell me they ran out of the medicine 4 days ago. Up until that time, the pain went from 7 to 0. They're without their medicine, and the last few days, the pain has started to come up again. It's back up to a 3 now. They also have osteoarthritis in their knees. And at the last visit in January, their pain level was maybe a 1 or a 2. It wasn't really bothering them that much. But 3 weeks later, they had to go on a long walk for a special event, and they walked far more than they should have, and their knee pain went to an 8 a week before their visit. And in the last few days since that visit, the pain level has dropped from an 8 to a 5. On top of that, the day before the visit, the patient sprained their ankle, and that pain is a 9 in the ankle. So hand pain went from 7 to 0 to 3, knee pain went from 2 to 8 to 6, ankle pain went from 0 to 9. So my question to you is, when they come to see me at their follow-up visit, what number should I put down on the chart that documents their level of pain? And whatever number I put down, does it adequately define what's going on with them? The answer is no. The number is worthless. So what I need to do is I need to write all that in the chart. But that's not checking a box. That doesn't get the reimbursement. So if you check a number in the box, you check 9, 5, whatever number you put, someone else is going to look at that and use that as a gauge when it has no meaning. Second question, should I say that my patient's level of pain has improved or gotten worse since their last? Improved, gotten worse, or is the same? And the question is, since when? Since their last visit? Since a week ago? The knee pain got worse from the last visit, from their visit a week ago because they were walking. It's gotten better over the last few days. Their rheumatoid arthritis pain got better since the last visit, but it's gotten worse over the last few days, and the ankle wasn't hurting them then. So how do I say improved, better, or the same? So the argument gets raised, well, what you should do is you should have a separate template for the ankle, and a separate template for the knees, and a separate template for the hands. And if I spend all my time documenting the pain to this extent, I don't have time to take care of the patient if I'm busy documenting. That's a problem. Then comes the diagnosis. For diagnoses, it used to be there were 13,000 codes for diagnosis. These are alphanumeric codes, A1GB2 is a diagnosis for something. So to give you an idea, in 2015, that number increased from 13,000 to 68,000. And I'm expected to put the specific diagnosis down. For gout, an arthritic condition that usually involves the big toe, there are over 240 diagnostic codes for gout. For diabetes, there are 1,000 or more. So I've got a patient, they've got diabetes. I want to have on my chart documented that they have diabetes, but I'm expected to put down what complications they have. Do they have eye complications? What kind of eye complications they have? What's the severity of them? Is it with an exudate or without an exudate? Is it the retina? Is it the cornea? I don't know all this stuff. I'm not an eye doctor. And on top of that, there's neurologic, there's kidney. I want to just write down this patient has diabetes, and I want to list it as a diagnosis, but I can't do that. One patient, the diagnosis required notation whether a particular blood test was positive or negative. I looked through 44 years of notes. I couldn't find that blood test. It didn't serve any purpose now. She had her disease, but I had to order another blood test on her just to satisfy the insurance company. So these are some of the problems we face in documentation. A study in the Annals of Internal Medicine a number of years ago revealed that physicians spend twice as much time documenting as they do taking care of patients. They also spend 1 to 2 hours a day after hours, after they're done with patients, doing clerical work, computer work, to clean up the charts and make sure everything's right. If we're spending so much time documenting, there's not as much time to take care of patients. Another study at the University of Wisconsin said that in an average 11.5-hour workday, physicians spend 6 of those hours doing clerical tasks. More than half their time documenting. And it's not documentation for patient care, because the electronic medical record and documentation is for billing purposes. And I just want to read you a quote from, oh no, I have to find it. A quote from a physician's blog who says the following. This is from Dr. Mom, who wrote on the medical blog Sermo. Am I the only doctor who is sick and tired of being told how much my time is worth? I have to justify my time and substance of visits for each payment. I'm spending more time documenting my visits than I am seeing my patients. If I see a patient for 30 minutes, I have to document for 30 minutes why I spent that time. I get the distinct honor of coding the assessments, and then I get to code quality measures. And Lord forbid I don't, then I don't meet the standard of care. Just whose standard is that? And as I said, the documentation is required for billing purposes, not patient care. Doctors Christopher Nade and Neil Skolnick, who are over here at Abington, have noted, quote, the patient's chart, once considered a sacred text containing the key inflection points in a patient's story, has become merely a filing cabinet in which to stuff every piece of data about the patient, no matter how mundane or trivial. This is what we're dealing with in documentation. This compromises the care that you receive as a patient, and it helps explain why a physician's nose is buried in the computer, instead of looking at you, making contact with you, examining you, and why physicians are so rushed for time that they don't have the time to spend with you. I'm not saying it's right. I'm not justifying it. I'm explaining it. That's documentation. Let's talk about prior authorization. Prior authorization is a process by which an insurance company determines whether or not they will pay for a particular diagnostic test or procedure. The way it typically works is, let's just say I want to order an MRI. My staff will submit it to the insurance company. The insurance company and the medical records, the insurance company may ask some questions or whatever, and they'll make a determination as to whether or not they're going to approve the MRI. If they don't approve it, then the next step is for me to write what's called a letter of medical necessity, explaining why I want the MRI. I'll never forget my first letter of medical necessity. It was for a patient in whom I was writing for Enbrel, which is a biologic medicine for rheumatoid arthritis. I wrote the following. Dear so-and-so, this letter will serve to verify the medical necessity for Enbrel for my patient, Mary Smith. Obviously, if I didn't think it was medically necessary, I wouldn't have written the prescription in the first place. It was denied. But this is the kind of thing that we're up against. The next thing is a peer-to-peer. And in a peer-to-peer, I have to speak with a doctor, a peer from the insurance company. That peer may not be a rheumatologist. In fact, it's usually not a rheumatologist. Sometimes it's not even a physician. It may be a nurse, it may be a pharmacist, it may be whatever. But this is supposed to be the peer. And I have to explain to them why I want this test, and they will decide whether to authorize it or not. So let me share one example. I had a patient come to me who had 6 weeks of ankle pain. This is my favorite prior auth story. 6 weeks of ankle pain. He had seen 2 other physicians. One thought he had gout, treated him for gout, he didn't get better. One thought he had an infection, cellulitis, treated him for that, he didn't get better, and he came to see me. He had had an x-ray, which was negative, and my first instinct was to say, we need to get an MRI of your ankle. I need to know what the anatomy of your ankle is. Is there structural damage there? Is a ligament torn? What? This has been going on for 6 weeks. My staff informed me that this was denied. They told me that the requirements for this were that he had to have at least 6 weeks of pain, which he did have, and he had to have a negative x-ray, which he did have. So I was confused as to why this was denied, but in any case, I had to do a peer-to-peer. I spoke with the peer-to-peer who was a pediatrician. Nothing against pediatricians. They're fine doctors. They're not rheumatologists. They're not joint specialists, any more than I'm a pediatrician and could comment on what a pediatrician should be doing. I said, why is the MRI denied? He said, the guidelines, not mind you, say that he should have physical therapy first. I said, that's malpractice. I don't know the anatomy of the joint, and to send him for physical therapy is potentially dangerous to him without knowing the anatomy of the joint. He said, we don't think so. I pushed. I said, is this a monetary thing? Is it because the MRI is so expensive? They said, no. I said, that's what the guidelines say. I said, you're asking me to commit malpractice. We don't think so. She refused the MRI. Now what do? Patient can't afford the MRI. I say to him, all right, I want you to go to physical therapy. I don't want you to bear weight on that ankle. I don't want you to do anything that's going to harm that ankle. And I want you to come back to me the next day and tell me that I couldn't tolerate the physical therapy. I tried, couldn't do it. He did that. We ordered the MRI. He had an occult fracture. It was malpractice, and I was livid. I ended up sending him to ortho. He got casted, and 2 months later, he was fine. I never saw him again. He didn't have a rheumatologic problem. But this was an insurer who was dictating care, and a peer-to-peer who had no expertise in my specialty, who was following guidelines. I'm not sure when guidelines became mandates. Following guidelines on how to take care of patients that were harmful to the patient. And I was expected to follow them. And if I had followed those guidelines, and he suffered an adverse event, it would not be the insurance company who was held liable. It would have been me. This is the kind of thing that compromises the care that patients received. Delays in care. The MRI that was finally done was done 4 weeks after I ordered it. What else could have happened in 4 weeks? Could he have injured it? Could she have stepped on it and the bone broken through the skin, a compound fracture? Lots of things. A survey by the AMA in 2021 noted the following. About 90% of physicians report delays in care because of prior authorization. About 90% of physicians report that the burden of prior authorization is either high or extremely high. 80% of physicians note that care may be abandoned. The patient just gives up on the care. I'm not going to get the MRI. 90% of physicians report that prior authorization has an adverse effect on patient care. 90%. But here's the most stunning statistic. 34% of physicians report that they've had a patient who suffered a serious adverse event because of prior authorization, be that a hospitalization, a life-threatening illness that required intervention, disability. 1 in 3 doctors report that because of prior authorization. Meanwhile, someone who has never seen you, never examined you, never spoken with you, is dictating your medical care with no liability. One of the advocacy things I've pushed in that regard is I've asked multiple legislators, not one has yet to do it, is can there be legislation that would make insurers legally liable for an adverse reaction that is a direct result of their denial of care? Right now, they are immune. So if an insurance company denies you care and you suffer, you can't blame the insurance company. That's a disgrace. That's prior authorization. These are some of the things we're up against. The third thing I want to talk about is scope of practice. Did you know that in 24 states, people without a medical license, a medical degree, or medical training are allowed to practice medicine? In 24 states. Pennsylvania's pushing to become the 25th. How can that be? That happens because the nurse practitioner lobby, the leadership of the nurse practitioner, are pushing for nurse practitioners to be able to practice without supervision. Now, nurse practitioners have training. They go to 4 years of college, nursing school, and then after that they have 1.5 to 3 years of a master's degree, which gives them their title of nurse practitioner. And they can do a lot of the things that physicians can do. They can write prescriptions, they can diagnose, and so forth. but only under the supervision of a physician. We have nurse practitioners in our office. They're very good, but they're under our supervision. We know what they're doing. I know who the good ones are, who the bad ones are. I know who I have to oversee more tightly and who I can give a little bit of freedom to. They're pushing in Pennsylvania to make it that nurse practitioners can just practice without the supervision. Keep in mind a couple things. When you talk about training, nursing training is different from medical training, both in the kind of training and the quantity. Nurses are taught via the nursing model. The nursing model looks at the patient as a whole. It doesn't focus on disease or diagnosis or treatment. It focuses on problems with symptoms. It looks at the support systems. It looks at function. These are all very important things. They run in concert as a complement to what physicians do. It's not what physicians do. Physicians are trained in the diagnosis and pathophysiology of disease and its management. Two different things that can both help patients, but they're not synonymous. The second thing, so the training is different. The second thing is the amount of training is different. Nurse practitioners require 500 hours of clinical training. That's 8 hours a day for 3 months. Contrast that with a physician who through medical school does medical school and residency does 5 years of training. You're talking about a difference of about 500 hours of training to 15,000 hours of clinical training. And those with 5 hours, I'm not saying every nurse practitioner, but leadership of nurse practitioners are encouraging that those with 500 hours of training are equivalent to what physicians can do, everything that physicians can do. They can't. And there's all kinds of horror stories about that. I mean, physicians make mistakes too. It's not just nurse practitioners, physicians do. And someone's pointed out that nurse practitioners who have a lot of experience may be as good as doctors, and that may be true, those who have many years of experience. But keep in mind, if you've got a bell-shaped curve of nurse practitioners, and those over on the right side are very experienced and very qualified and have done a lot, and those on the left side are just out of training, allowing nurse practitioners the right to practice medicine, you're getting both of those groups. So why would this be? Why would anybody push for that? The answer is because of the corporatization of medicine. You have entities like CVS, who runs their minute clinics. They want to staff them with nurse practitioners. Nurse practitioners are less expensive than physicians. So if they can hire nurse practitioners instead of a physician at their many minute clinics, then they can provide care, they can reap the rewards of that without having to pay out a nurse practitioner. Now they might take the risk on of a malpractice suit, but the amount of money in a malpractice suit pales in comparison to the amount of money they can generate by not having to have physicians staff their minute clinics. And what they're banking on is that patients want convenience. And what they're doing is they're sacrificing the patient-physician relationship in order to control the healthcare dollar. And that's a common theme. And it ties in with entities like CVS, pharmacy benefit managers. There's a chapter in the book on pharmacy benefit managers and group purchasing organizations, insurance companies, all in the name of, quote, cutting costs. But cutting costs to whom? And for what purpose? So these are some of the problems that we face. Employed physicians may be asked to supervise nurse practitioners. Now you're responsible for someone else's work. And it's not by your choice, you're mandated by the administration. One of the graphs that I oftentimes show in my talks is a graph showing the growth of physicians from 1970 to 2020. In that 50-year period, the number of physicians has approximately doubled, 200%. There's another line on that graph which shows the growth of administrators, hospital administrators, insurance executives, etc. They have increased 30 times, 3,000% compared to 200%. And the administrators are very often dictating the care that patients provide, and the care that patients get, the physicians provide. And one of their strategies is, frankly, to devalue what physicians do. If they can make the argument that nurse practitioners are just as good as physicians, they don't have physicians combating them on how to practice medicine, and they can dictate medicine, cookie cutter, one-size-fits-all medicine at a less expensive price and reap more profits. Think about going to Baskin-Robbins and them telling you the only flavor we have is vanilla, because that's the flavor that most people like. Well, I like strawberry. Sorry, most people like vanilla. Well, it would cut their costs tremendously if they only had to manufacture vanilla ice cream. The problem is that people could choose not to go to Baskin-Robbins. People can't choose not to go to healthcare. So what can we do about all this? There's lots of problems here. One of the main issues that we face is, one other thing I forgot when we talk about nurse practitioners, very important, and I forgot it, is the use of the term provider. Just a question for you. How many people in the audience see a physician? Raise your hand if you see a physician. Raise it high. How many people see a provider? That's surprising. Nobody raised their hand, because there is a push that to make healthcare across the board equal, that we're all providers. And in fact, I've seen physicians who have commented on nurse practitioners not being as adequately trained, who have been fired from their job for not being team players. We have to show respect for other professionals. Well, physicians and nurse practitioners are not interchangeable. One thing that'll be relevant to this audience is the use of the word provider actually has some of its roots in Nazi Germany. In Nazi Germany, Jewish pediatricians were called Arzt, doctor. That was their title. When Nazi Germany wanted to devalue physicians, they changed their title to Behandler, which means provider. It was their way to denigrate what physicians did and to make them less important, because physicians with their expertise are more likely to stand up for what's right in terms of the science. They didn't want that. They didn't want physicians telling them how things should be run. So that was their way of devaluing physicians. Now, please, let me make it clear. I'm not comparing the use of the term provider today to the atrocities of Nazi Germany. But what I am saying is that just like in Nazi Germany, when you want to devalue physicians, one way to do that is to label all healthcare personnel with the same title. And I want to read a quote. This is from the New England Journal of Medicine that was written by two doctors, Pamela Hartzband and Jerome Groopman. And this is, I think, very powerful. And I want you to especially listen to the last sentence. They say, "The words we use to explain our roles are powerful. They set expectations and shape behavior. This change in the language of medicine has important and deleterious consequences. The relationships between doctors, nurses, or any other medical professionals and the patients they care for are now cast primarily in terms of a commercial transaction. The consumer or customer is the buyer, and the provider is the vendor or seller. To be sure, there is a financial aspect to clinical care, but that is only a small part of a much larger whole, and to people who are sick, it's the least important part. The words consumer and provider are reductionist. They ignore the essential psychological, spiritual, and humanistic dimensions of the relationship, the aspects that traditionally made medicine a calling in which altruism overshadowed personal gain. Furthermore, the term provider is deliberately and strikingly generic, designating no specific role or type of, or level of expertise. Each medical professional, doctor, nurse, physical therapist, social worker, and more, has specialized training and skills that are not recognized by the all-purpose term provider, which carries no resonance of professionalism. There is no hint of the role of a doctor as teacher with special knowledge to help the patient understand the reasons for their malady and the possible ways of remedying it. No honoring of the work of the nurse as a nurturer with unique expertise whose close care is essential to healing. Rather, the generic term provider suggests that doctors and nurses and all other medical professionals are interchangeable. Now listen to this sentence. Provider also signals that care is fundamentally a prepackaged commodity on a shelf that is provided to the consumer rather than something personalized and dynamic, crafted by skilled professionals and tailored to the individual patient. Just think about what that says about where healthcare is and how people who control healthcare view it. So what can be done? Well, we're in a bind here, folks, because we're about 20, 30, 50 years too late. Corporate America has taken over healthcare, and not for the betterment of patients. Private equity is controlling emergency rooms. Their goal is the bottom line. It's not about the patient. We have two inoperable tumors in our healthcare system. They are greed and a desire for power. And they run rampant through our healthcare system. And those who control our healthcare system are inflicted with these. And it makes it difficult. So what do we need to do? First is education. And education runs the gamut from teaching people about illnesses, from teaching people about how their insurance companies work, teaching people about pandemics. We need to educate our patients. We need to educate our patients how to get the most out of their doctor's visit. We need to educate patients how to advocate for themselves. Advocacy can be at the general level where you're talking with legislators to change policies or laws. It can also be at the individual level where an individual patient needs to learn how to advocate for themselves or a loved one. So we need to educate patients. There's a problem with education. And the problem with education is that trust is gone. We've lost trust. The political atmosphere has destroyed trust. So how do you teach patients to trust? Education. The answer is individual care, patient-physician relationship. They need to have a physician that they can trust. The second thing we need is transparency. Prices are not transparent. It's not even transparent as to who is taking care of a physician, taking care of a patient. A nurse practitioner who's attained her doctorate may walk into the room and say, I'm Dr. So-and-so, and never explain they're not a medical professional. But mostly, we need to restore the humanity in medicine. Let me tell you one last story, and then we'll finish up. This is a story about the importance of humanity and what medicine is all about. I had a patient with vasculitis, which is an inflammation of blood vessels. He was in the intensive care unit when I met him. He was very sick. Vasculitis is something that is potentially life-threatening. We nursed him through his stay. He got out of the intensive care. He had some setbacks. He had a minor stroke and so forth. But he made it in my office. I began to see him in the office. And I got to know him, and his wife would come in for visits. And in fact, I would see him at my gym. He trained at my gym. And we got to talking and so forth. We became friendly. And one day he announced me that he was moving to Florida and so forth. His wife came in with him to his last visit. And she said to me, and by this time I was already outspoken and I had vented a lot of the stuff that you've heard today. And she said to me, the next time you get frustrated with what's going on in medicine, I want you to remember my husband. Because not only did you make a difference in his life, but you made a difference in the lives of all the people who know and love him, because he is still around. And I think of those words often, and they are inspiring to me, and remind me, give me that reminder with all the stuff that's going on in healthcare bureaucracy. That's why we do what we do. And let me just finish with one final excerpt from the book, and then I'll open it up to questions. The single greatest joy in medicine is knowing that you have made a positive difference in someone's life. When you think about it, that is all we can really ask for as physicians. I have been fortunate to experience that many times. Samuel Shem, in his novel The House of God, writes that the most loving thing we can do as physicians is to, quote, be with the patient. We cannot always cure, we cannot always relieve suffering, but we can always be with the patient. That is, share their lives, commiserate in their sorrows, revel in their joys, and most importantly, validate their experiences. The caring may actually be more important than the curing. This is the art of medicine, and is why the physician relationship is the core of healthcare. There is no substitute. Healthcare is ultimately a human experience. Throughout all of this, that is the most valuable lesson I have learned. That is something that is worth fighting for, and that is why I'm a healthcare advocate. So with that, I'll open the floor up to any questions that people have. And there's a microphone here. Rob or Barry, how do we want to do this with microphone? I guess we can take it to people. Well, Steve, why don't you just yell out your question? I'll repeat it.
Steve, can you give me one moment? This is because of those on live stream. So if you would take
this country is based on capitalism, and insurance companies have to report their bottom line, their earnings per share, and we know how basically they're construed, that you pay your premiums, and the insurance company, minus the operating expenses and payout for accidents, approved pre-authorizations, are left with so many dollars, and that's what they have to report to their shareholder, which is on our 401ks. So, it is a mountain, a big debacle for us to try to reverse that. So I think, and we're talking about what could we do barring any ceilings? And one is to ensure that maybe those that are officers of the insurance company or within the insurance company are held liable for any of the decision-making as far as rejecting pre-authorizations or ways to keep the premiums reasonable, which they're not. We turn around and people are complaining that I can't afford my premiums. It's either going to be my medicine or food. I got to go with the medicine. We'll have to starve. So that's one solution that is just, pie in the sky. This is, we're talking, what if? What could we do? The other thing is, I think people have to have realistic expectations. I'm a dentist. People come in and they have loose teeth, and they think, well, I don't know how. No one along the line has explained to them. Maybe there's a systemic problem, or it's poor hygiene or whatever. And I got to be the one to tell them, and they have no idea what I'm going to hit them with. And I say, you could lose all your teeth. He said, wait a minute, I never heard that before. So then again, I'm going back to the idea of educating people in a preemptive fashion so that people can be in control of their life and have realistic expectations, so they don't walk into your office or mine and expect, I'm going to live forever, or I'm going to shake this and that. If they understand that there are limitations and we're not God, we can't make people whole, that will reduce their expectations, and that could reduce the possibility of you being sued or me being sued for malpractice. The third thing is, we live in the society we lived in 100 years ago. People were doing physical things, whether it was work around the house or going to work. We live in a society today where we are on our phones, computers, we're eating unhealthy foods, we're sedentary, and then we don't understand why all of a sudden, why are we sick? Why are we at the doctor's office once a month? So I think we have to look ourselves in the mirror, take control of our mental and physical health, and optimize on that through better wellness training, wellness behavior. Anyway, great job, Mark. Thank you.
Addressing your comments, first of all, the first thing you said, I agree wholeheartedly. I have pushed a number of legislators in that regard to no avail. I agree with you wholeheartedly. Your second comment about expectations is very true. To look at that, all you got to do is look at an ad, any type of healthcare ad for a pharmaceutical, for a hospital. Think of what ads promise you. They promise you relief from whatever's bothering you, quickly, with no side effects, at no cost. And if that doesn't work, there's a lawyer's ad which says there's somebody to blame because you didn't get the outcome you wanted. So, yes, expectations need, and that's part of the education. What can we realistically expect? As for the third thing, you're talking about social determinants of health, and that is a critical area in terms of improving the health of our population as a whole, not just in terms of our lifestyles, but also in terms of communities that don't have grocery stores, that somebody's got to get on two subways, get on a bus and a subway to get to a supermarket. We have to consider what we want as a society. And you're right about the comments about capitalism. And there's a great divide in this country about how to handle this type of thing. And there's no easy solution. If you go, away from that, there are problems with it. So there's no panacea here for results. But education and transparency and realistic expectations are the things that we need to do. So yes, I agree with most of what you said. Other questions?
Thank you very much. Gary, give me one moment if you would.
Harold and Gary.
Harold.
Hi, Mark. First of all, thank you for sharing your journey. I found it fascinating and would love to hear more. Read the book. And you said so much that has so many questions in it, but the one I want to ask really has to do with patient-doctor relationship, as you talked about. And I think we all agree that that relationship is as important, if not more important sometimes than, as you said, taking the right pill. So my question is, with the bureaucracy, with the corporate policy, that physicians who are no longer self-employed, but work for these conglomerates, these health systems, and they have their own bureaucracy to deal with. While it might be possible to keep that relationship with your PCP, you go to the hospital, your doctor can't come see you. He used to stay at his practice. So how is a patient, I guess it's a two-way street, do you develop that personal connection, that relationship, that feeling of comfort and trust with professionals who you may see 2, 3, 4 days and never see them again? And I think that's a problem if you need hospitalization, because you can't get that comfort from your personal physician.
No, you're absolutely right. And you're seeing people that you have to form an instant trust, and a lot depends on the physician's skill. I recently had a procedure done where I needed anesthesia, and the anesthesiologist, whom I'd never met before, and I'm a physician, came in and saw me, and within 2 minutes had me feeling comfortable about what was going to happen. He was very skilled at it. Not everybody is. And physicians are serving two masters these days. They have their patients and they have their corporate, if they're employed, they must satisfy their employer and so forth, which makes it very difficult. And sometimes things that you can do as a patient is to say, let's stop for a second. Can I ask you a question? Something simple like, tell me about you. How are you to the physician? How's your day going today? Just something to establish that little interpersonal relationship can go a long way. It's not going to solve everything, as physicians are rushed and so forth, but to try to get that physician to see you as a person, if you see them as a person, that's something that you can do. A little thing. Hey, can you explain that to me? I'm not clear on that. When will you be back? Whatever. But one of the things is that it will help patients if they are able to be more assertive and are able to advocate for themselves a little bit better. And there are lessons. I give a lecture on how to get the most out of your doctor visit. There are talks there are things that you can learn, conscious things, that can help you get along better with that in that situation. In that situation, 2, 3, 4 days in the hospital, you're stuck for those 2, 3, 4 days. But I've had patients where, and I wrote about one in the book, where I made the diagnosis and ordered a life-saving MRI simply because I knew the patient that well. I knew something wasn't right. It wasn't that I'm such a smart guy, it was that I knew my patient. So there's a lot to be said for the patient-physician relationship. And these days, people are more interested in convenience. They're more interested in going to that minute clinic with a sore throat than seeing a doctor where the relationship is formed. The values have changed from where they were 20, 40, 60 years ago. And that's a big problem that you allude to. I don't have an answer for you, a solution. So, Gary, you had a question?
Gary, would you take this? I think we need to... Esther, do you have a... We'll make yours the last question, all right, if you don't mind. Thank you.
Mark, again, thank you very much for coming. You've provided a wealth of information. I see about 3 doctors. 2 of them are specialists. One is my personal internist. And for the longest time, I've had Blue Cross and Blue Shield, who they've been nice to me, and I'll be somewhat blunt, they've been awful pain in the asses. They lost a check that I had written, and I'm old-fashioned. I use the big, old-fashioned accounting checkbooks. And when there's a problem, I always have a check stub to go back with and a copy of the check that I wrote. So I received a letter from Blue Cross, and they said that if we don't receive your payment, we're going to cut off your insurance. I called them. I said, the check was mailed. I have proof that it was mailed. I have the check stub, I have a copy of the check, and I have your statement. That didn't seem to be good enough, and I put a stop payment on it, and I wrote another check. The same thing happens again the following month, and then the month after that. They didn't receive the check. It didn't come back as an outstanding check on my statement, and this has been a series of things that have been going on for years, that it would take them a month and a half, 2 months to clear the bank, and I've already received it as a check outstanding. So the last incident that I had with them, I spent about 4 hours on the telephone. Two hours with one schlepper and about 2 hours with talking with 3 different schleppers. And I finally got to speak to a supervisor. And she said, well, if you don't pay your premium, we're going to cut you off. I said, well, wait a minute. I've been a loyal customer of Blue Cross and Blue Shield for more years than I can count. I mailed the check. I said, now what else do you want me to do? I can't control the post office, but I know that it's probably sitting in your mail bin someplace and somebody hasn't opened it. I said, well, as soon as we get the check, we open it within 2 business days, and that's the end of it. You have insurance. So I said, well, I can't control the post office, but I know when I sent my check out, because I have the stub and the statement and a photocopy of the check that I sent out. This
Gary,
Michigas keeps going, and
Is there a question here?
yeah,
Okay.
they said that in order for me not to cut your insurance, that I would have to send them a check through their electronic system and have the insurance paid for. What can the consumer do to get them off your back and not threaten to cut your insurance off when they know that you've paid your bill time and time again, but you can't control the bank, you can't control the post office?
3 places you can go. 1, contact the insurance commissioner. 2, contact your state representative. That's the kind of thing a state representative can do. And it may come down, you may need to hire an attorney. I mean, those are 3 things. That's a battle, David versus Goliath, and it's a very difficult one, and there's no easy solutions there to get through the bureaucracy. The other alternative is to do what they're asking and use the electronic system that they're asking you to do. You shouldn't have to do that, but if it will avoid this kind of hassle, that may be the best way to go. But those are several avenues that you can go through to try to rectify that.
Because I also threatened contacting the president or CEO of Blue Cross.
Do that too.
And I know that it's going to be passed down, but it's very aggravating when you spend so much time talking to the insurance company and then they're threatening to take your insurance away when they know that you've paid your bills on time. It's just...
It's very frustrating. I share it with you.
infuriating. It's absolutely infuriating.
Yes, I don't blame you for being angry.
Mark, one last question from Esther.
And I'll be available if people have questions afterwards.
It's not necessarily a question, but with regards to the nurse practitioner and all, my son was a practicing physician in Harrisburg. I know how it all got started at the legislative level because one of the representatives was a nurse practitioner. Mm-hmm. She pushed it. It came before the general body, and 2 of our representatives, one of them no longer in office, agreed to go ahead with what you said about nurse practitioners not being supervised and doing everything on their own. My suggestion is, even if you're not political, and this is a concern of yours, which it should be, you need to pay attention to your representatives, what they're doing and what they're pushing, and if you don't like it, get active and tell them to stop it. If enough people are concerned about this and write to their representatives, they're worried about their constituents. You might be able to stop this from happening in Pennsylvania. That's really all I want to say. And
I would agree.
Appreciate what you've educated us with.
So let me thank all of you for coming. I will be available to answer any other questions that people have, and have a good rest of the day.
Thank you. Thank you so much for being here today. Thank you to our fellow Bethamniks on live stream as well. Mark, I've never come across such an eloquent and passionate speech about the nexus of the cure and the care, or sorry, my apologies, the care and the cure of an individual, of a person, of a patient. Thank you. Thank you so much. God bless you. Thank you indeed. Thank you, folk, once again for being with us. Shavua Tov to all of you. Shavua Tov.